right, so we heard a little bit about vaccines this morning and what's in the pipeline, and now we're going to be talking, changing the topic a little bit to talk about what would make people consider participating in a challenge model and what that's going to look like. So I think we should have some interesting presentations, and it's my pleasure to invite up Manolia Sag to introduce our first speakers. So I'll...
Okay, yes, you guys can all hear me? Great. Yes, so it is my pleasure to introduce Dr. Kimberly Page. She is a distinguished professor in the Department of Internal Medicine at the University of New Mexico. And Dr. Page is trained in infectious disease epidemiology and is a leader in research with HCV and HIV infections in high-risk populations. She also leads a number of different networks and research clusters. To name one, she is the PI of the Southwest Node of the NIDA Clinical Trials Network, which aims to expand the infrastructure and research for science-based prevention, therapies, and treatments to patients and substance use disorders. She is also a member of the CanHepC NM Coalition and has many ongoing studies of HCV infection, substance use, and integrated care across New Mexico. So join us in welcoming her as she tells us about her experience with that recent HCV vaccine trials. Thank you.
Thank you. Thank you very much. It's a real honor and pleasure to be here. This is where science is happening. My kids asked me why I came to Canada. That's why, because it's cold here. But it's a pleasure to be here and to see so many colleagues with whom I've worked over the years. Thank you very much for the invitation. So what have we learned? This will be very short, and we continue to learn. But I think one of the really important things that we did with the vaccine, with the VIP trial, was show that we can do it. It was an extraordinary effort, and enrolling people who inject drugs was a wonderful challenge. And let's see, how do I, there we go. So the VIP study, which you have heard some things about today, and I'll try to give you maybe some of the other side of all of the pokes and blood draws and AE events that we established. We know it was a placebo-controlled, double-blinded trial. We looked at safety, efficacy, and immunogenicity of this vaccine. At enrollment, participants had to be 18 to 45 years old, hepatitis C negative, and they reported injecting drugs. They were randomized like any other trial. You've seen the results. We had no difference in infections. We did have a big difference in peak viremia. And this is what we said we did. I have to advance two things at once. So, hello. Well, there we go. Sorry, I'm having challenges. So we actually call this herding birds. Herding birds, the recruitment and retention of a highly disenfranchised population. Now, this is the language we used back then. It hasn't changed too much. Underserved, disenfranchised, and for the most part, not cared for. Although we have these pockets, beautiful community pockets like we've seen here today. Herding birds was coined by one of our outreach workers, Casey Cullen. So here's some of the things that we learned, because that's what I promised to talk about. So first of all, with recruitment, you have to have a plan. Actually, you have to have 2 plans, maybe 3 plans. You have to have many plans for recruitment. You have to be very nimble and very responsive to the pressures that the population faces: transportation, housing, remuneration, information, and misinformation. Recruitment nowadays, I think, as I've expanded my clinical trial activities into people who use drugs all different ways, this still holds. Have many plans. Eligibility. As with any trial, and this is a very important thing that we had to learn to deal with early on, my co-lead, Andrea Cox, and I, and that was what's normal. So in a vaccine trial, you are testing people who are healthy to try to prevent them from getting a disease. You're not looking at people who have a disease and trying to help them get well. So healthy people requires extra surveillance. And with any trial, it's very clear to define this eligibility criteria because standard guidelines for healthy may have to be reviewed and revised. Again, being nimble is very important. And you can use this to your advantage. For example, we found many women who were anemic, and they didn't meet the criteria. So can we safely include them? Can we provide them with information and resources for iron supplementation and bring them back? We had that kind of experience where we had to redefine healthy. And because of that, also, we had that phased trial. We had a trial where we did an interim analysis looking at the safety data before we moved on into the efficacy component. But what's healthy is maybe a little bit broader or maybe a little bit different. Informed consent. And enrollment. So being that this is a trial with an experimental product, it's a really big deal. I mean, we were a first-in-human trial. And communicating that to our participants was really important. So being really clear about the requirements and challenges that people will face, we did comprehension assessment after the informed consent process, and that was basically ongoing throughout the trial. But the most important stuff that happened out in the field with our outreach workers was, dude, you just got an experimental vaccine. You got to come in. We're the only ones who can tell you what's going on. You have to come in. You're an experiment. And they had to go out and just really knock people, like, you got to come back. You got to come back. Informed consent, I don't think has changed much. I think you can still do this. And if anything, this is my personal view, since COVID, people have become far more literate about how we're testing for virus, what PCR is, and even, yes, our people who inject drugs can be extremely literate in these areas. We find that now in our trials that we're doing. So you can give them information, they can soak it up, and if they have questions, they can always come back. Because remember that the informed consent process is ongoing. People can drop out anytime they want to, which you're trying to avoid. So our plan for success, we had a very in-depth outreach plan that was developed by site. What they did in Baltimore was different from what we did in San Francisco, which was different from what we did in New Mexico. And this is really important because this is kind of an epidemiologist's mantra. All epidemics are local. So what happens for your recruitment and retention really needs to be a local plan. What works in San Francisco may not work in Albuquerque or Baltimore. And so that's very important. Your local partners are extremely important. Recruitment happened on foot, by bicycle, by RV. We had all kinds of recruitment, and we had these signs everywhere. The clinical research site was situated in the Tenderloin in San Francisco, and in Baltimore, it was at BBASH, I believe, right, which is also centrally located. And in Albuquerque, we located it at one of our off-site clinics that was out in the neighborhood that treats people with HIV and hepatitis C. So we had accessible sites. At one point, we had Twitter moved in across the street from our site in San Francisco, and all of a sudden we lost our space because the rents went up. We had no space for our trial, and our trial was a community-based clinic that we refurbished and bought everything for. We had to move to the hospital while we waited and tried to get the CTSC to support us. They didn't really want our people in the hospital, and our people didn't want to go to the hospital. And it was really challenging for a while. really challenging when we didn't have a space and we had to find another space and pay rent, and those things happen in a trial. We had a really aggressive retention plan, and these are easy to do, but we've learned a lot since then too, I think. We now have databases that link medical records across geographic areas, so we can look up people. Street medicine has become one of the most popular things for med students in the medical school, and we recruited everyone from, nowadays we recruit everyone from street medicine to help us with our recruitment and retention, because those folks are out there providing services and gaining a lot of trust. So taking advantage, and we didn't have a big street medicine program then, but now we even have one in Albuquerque. So this is something that we use regularly for many of our trials. Toll-free phone number, phones. We put everything in place. What gets used and not used varies by day, time, and season. When it's cold out or when it's hot out, things change. When it was really hot in San Francisco, our -80 freezer would go wonky, which was really a problem. But we did have a really good view of the 49ers Super Bowl parade. It was right on Market Street, so you can see how centrally located we were. In Baltimore, they had this fantastic van, RV, that went around to different neighborhoods, and the team was just the most caring team there ever was. So everything we hear about respect and dignity, those are key to recruitment and retention. Oh, yep, that was this is like one of our big, we put signs everywhere. Signs everywhere, and this is a San Francisco sign. You can see it in the neighborhood. Big challenges. Loss to follow-up was really high. We have high rates of incarceration, high rates of death, and moving. People move around. Even though inclusion criteria, people agreed to stay in the area for 2 years. Life's not like that. Life for our participants, for many of them, was very chaotic. Different policies and things can happen in the field that impact your participants, like police sweeps, where they come in and just destroy encampments, take your belongings, including your VIP adverse event diary, and then what do you do? So we tried to be really, really responsive with that, and preempt it whenever we could. We made friends with a lot of police. We were from UCSF. We had little badges. We had made sure that we had a lot of entree in the community and understanding. The incarceration rates are serious because you can't follow people when they're in jail unless you get OHRP approval, which we had, actually. And so you do have to jump through extra regulatory hoops to make sure you can reach all of your folks. Missed visits were a continuous problem, and that's where we got heavy-handed, like, dude, you're in a vaccine trial. You're gonna help change the world. Comorbidities were really significant. Mental health, poly-drug use. We talk about poly-drug use like it's a new thing. It's not a new thing. It's been ongoing for a really long time. And there are many effects of the different drugs that we don't really know how they all work synergistically, but we can get that information from our patients. They're the experts, and I think that helped us a lot. We had one of our most significant experiences was a guy that showed up with a rash. And it was a great experience because we didn't want a rash. This was an immunogenic vaccine. A rash was a big red flag. And NIH said, well, you got to get this guy into dermatology right away. And Dr. Cox said, I'm faculty in Baltimore at Johns Hopkins, and that would take me 6 months. So, and then one of the doctors on the study, one of our monitors said, yeah, we don't keep them in cages in the basement, you guys. This is a big deal. And we also had someone develop diabetes, so the monitoring was really intense. Luckily, we had pre-vaccine blood, and we could establish that this person was at high risk before we vaccinated them. But being on the lookout for that, and now you understand why we have to bring people back. The guy with the rash, by the way, had just gone off his Librium, and it was shaving his face. We had an exclusion criteria for people who weren't on controlled meds for mental health issues. Most people were really, really adherent to all of that. And we just managed to get this guy back onto his regimen and continue him. But those things don't happen in other kinds of trials. So how we did it, we were on the street. Outreach workers mapped routes on foot. We had maps on foot and bike to identify areas of recruitment and appropriate times. We established a presence, a regular presence. We had secondary recruiters who enrolled participants who were trained to refer people to the study and inform the outreach workers of new places to go. So we had like sentinel outreach workers. We had a lot of education, tons. We worked with many, many agencies who serve people who inject drugs, including syringe service programs, community clinics, who provided hepatitis C prevention education trainings for staff, clients, that included all of the study goals. There was a lot of pre-existing relationships. I don't know how other people would do it, but Andrea and I, we had a cohort. We had a cohort that we watched for 10 years before, and we were just waiting for a vaccine. Now, when I was a grad student, I worked on the Young Men's Health Study in San Francisco, population-based study of HIV in that city. And my major professor, Dr. Warren Winkelstein, when the first HIV vaccine came out, said, no, you're not using this cohort. Because once you use that cohort, you can't use them again. And so we really waited for what we thought would be a viable vaccine. It didn't turn out that way, but we did learn a lot. Guard your cohorts. Make sure that you have something viable before you put everyone in a bell jar that they can't then re-participate. Collaboration. We had all kinds of collaborators, flyers, everywhere. SROs, that's single room occupancy, hotels, where very often people who are experiencing homelessness are sort of placed. Any place where a person with who injected drugs was likely to be. And in the clinic, we had a lot of cultural competence testing about optimal ways to engage, build trust, being available, avoiding judgment. We had these great relationships, but everyone had to be trained, including the nurses. I never got to be on call very often because I'm not an MD, even though I want to be on call. And most of our events are really social, not medical, right? They're not clinical. So sure enough, we had a nurse call me up one day, and I got to be on call. It was like so fun. And she says, I have a patient here with scabies, and I can't let him in. I said, glove up, gown up, and see the patient. Is that a pretty good doctor thing? Yeah. I go, you know what? We've got a box of clothes in the back room and all kinds of things where people can, find clothing and jackets and smocks. Put one of those on if you don't have a gown and see the guy. I don't care if it's in the vestibule, but see the patient. That was like my one win. But even our nurses, we had to educate them. And, finding clinical nurses who could work on a vaccine trial, there was education and training too, because it turned out that the younger folks who were maybe a little bit more adaptable found it not so abnormal to work with this population. And you have to make sure your staff is all on board. Retention. We have contact forms. Everyone has those. Contact information can be collected where they are. It's not always great. Participants are really seriously queried about where they spend time, where their friends are, do they have family, can we contact them? We get approval for all of this. We got photographs of people with their permission and took a face shot so that we could find them. A few people did not want their photograph taken, which was fine, but so we asked them to draw a picture of themselves, and it still gave them something to do and a way to, link into the trial. So it was really was quite good. Our database was all, we actually developed our own database using a SQL kind of database. We didn't have, this was 10 years ago, so we didn't have as many great tools as we do now. But tracking notes have to be continuously updated. Reminders, study reminders, and no-shows. If they miss an appointment, we got into action. We would look in the paper, we would look in the jails, we would look everywhere we could. And then we also eventually got some smartphones, and our team carried those around. I finally got the dance down here. So here are some key take-home messages. It's a really important and opportune time now to take advantage of the interest and innovations happening in vaccine development. And it is a great pleasure to be here and hear about these developments. I'm with you. Let's get some phase 1 trials going. I'm with you. Most importantly, we need to continue to engage with these folks and communities at risk of hepatitis C and many other of the associated negative health consequences that come with injecting. Oh, injecting's reducing? Guess what? It is reducing, but we're still seeing a lot of Hep C. In Albuquerque, we're not shooting heroin anymore, although we got a little bit back, which is good. They're shooting meth. So they're on MOUD, or they're using fentanyl, but they're shooting meth. So we really haven't seen a reduction in our hepatitis C virus infections. Many participants really enjoyed the frequent contact with the VIP team. There was a lot of positive feedback, including feeling useful, feeling responsible to the VIP study, being able to demonstrate reliability and take their research participation quickly. Every single person who wanted it was given referrals to drug treatment. People who got Hep C were given referrals to hepatitis C treatment, which wasn't so great at the time. But they liked, it wasn't a negative experience. And I think you can continue to engage, but we need a viable vaccine. Controlling Hep C may require one or more vaccines and all the many tools that we have in our toolbox. We don't have one magic bullet, and I don't expect we will, but we can't give up the tools that we already have. And I want to thank, we are indebted to the participants in this research from whom we really learned how to be very equitable and improve health. I'm very indebted to Andrea Cox and all of the collaborators on the VIP study, and thank you for inviting me.
So because we're going to switch after Kim's talk to talking about the challenge models, if people have specific questions about the VIP study that you want to ask Kim, we can take
my hero.
Well, I don't know about that. You're my hero. Well, I mean, Kim, it's great to hear from someone who have boots on the ground in vaccine trial and share these challenges. And I think it's, I tip my hat to you and your coworker be able to get this done successfully, you and Andrea and others. So I was going to ask you, I assume you remunerate these for money. And I don't know how much you gave, but do you think there's a sort of sweet spot that you can pay them enough, so not so much of inducement, but also give them enough to keep them in the, in the system, that they have some incentive that feel like, well, they have some investment in.
I love that question. I think that behavioral economics shows that paying people to stay healthy can be an effective way to do it. And I have no doubt that if I did this again, I might consider an escalating or a different type of remuneration thing to make it more fun and to increase and to keep interest in it. And there's been a lot of work on remuneration and asking people what they want. So yes, it's a big deal. Is there a sweet spot? That varies by location. We can pay $50 in one place, but your IRB may not allow that. I'd pay him $100 per visit. I'd pay him more if I thought that was important.
And so, depends on the location, as you said.
It depends. Again, I go back to my early epi training.
Yeah.
What happens in Baltimore is a little bit different. Yeah. But we do know, too, now, we're on another planet with the drugs, with everything that's going on. We've got, I mean, Julie Bruneau said it, we need new data.
Yeah.
So that'll be a place where potentially I can help.
Yeah, this would be a very relevant point for the CHIM study, right? I think how much. So, but thank you. Thank you.
Thank you.
Thanks, Kim. And ask Manolia to come back up to introduce our next speaker.
All right, next up we have Paul Zimmer-Harwood. He is the research lead for the clinical trials at One Day Sooner, and within the organization he is responsible for research and coordinations on issues related to hepatitis C and other human challenge studies and the research participant representation.
So yeah, thank you for the kind introduction. Where do I push to get the next slide? If I want to, just this one? Okay. Cheers.
Oh, but you want to see.
I think I can just, no. This works. This is fine, thanks, John. Yeah, it's incredibly exciting for me to be here, actually. This is my first invited talk ever, so I hope you can hear how positively excited I am. So thank you so much for the opportunity to come here, first of all, and talk on behalf of One Day Sooner about the perspective of participants in CHIM trials, so another study population that I think shares with the population that we've just heard about, that they want to contribute to science and feel useful. And also personally, just it's always, I think, a crazy privilege to be in a place like this and to learn from people like yourselves. I always quite enjoy that. So I'll just give you a little bit of an idea of the organization that I work for, because I think there's a lot of confusion about what we do, given that we're such a niche organization. And yeah, I hope you find it interesting. And then talk about what actually motivates CHIM participants generally, and then also look in how the hepatitis C CHIM, as it's proposed, will stack up in those regards. So our background is that we were founded in the very early 2020 time when the pandemic started, or where a lot of people thought they'd like to volunteer in a COVID-19 challenge trial in order to get a vaccine faster and get better data faster. So it's really kind of the other side of the spectrum in terms of what kind of you have to do to get participants into the lab. These are people that sign up preemptively and ask like, hey, what are the trials that I can participate in? I want to contribute, I want to do something. And so we now have about 40,000 people in our database. They're quite focused on the Anglosphere, so a lot of them are in the US, though Canada basically, if you look at it on a population level, is just as many people. For some reason, a lot of people in Brazil, it might be because it was specifically hit hard by the pandemic, but I don't know that for sure. And in Europe, it's a similar picture. But actually, if you look at Scandinavia, if you look at the population sizes, it's not too far off from how these English countries are doing. And these are basically people who specifically signed up to be informed about CHIM studies in their area. Jenny. So within One Day Sooner, we have what we call the cooperative participant organization, and we really try to be like a gear between people who want to be in studies and study sponsors to elevate their voices. And basically our core belief is that adult people who have an understanding of what actually they're getting themselves into should be allowed to do that and take a risk to the benefit that they want to benefit to, and take CHIM and general medical study participation out of the fringe and make it as universally recognized as blood donation, for example, or organ donation. So we organize volunteers, and we, as I said, strongly believe in their autonomy. We engage in advocacy also with policymakers, like the cooperative participant organization team less so, but the broader One Day Sooner organization. And we really just want to elevate the voices of those people who want to participate, make them stakeholders in the science instead of just being researched on, and just give them a general platform. All right. So about me, how to get into this kind of job. So I'm a scientist by training, but I'm a neuroscientist. So that very much means I'm not a medic and I'm not an immunologist. So we heavily, I'm also the only full staff scientist. So that means we heavily rely on experts like yourselves in order to form our opinions, because we can't cover it all. And we're not just involved in hepatitis C, but in basically all kind of CHIMs that exist. just type-wise, we don't really are involved in every single CHIM. We're too small for that, but we try. But what I have done is participate in a lot of research trials myself, starting from my undergrad degree, where it was basically a requirement to do some participation hours in order to get your degree. But ever since, I've also done metabolism studies, donated bone marrow, fMRI imaging studies, you name it, but also malaria and COVID, CHIM, and obviously, here are some beautiful pictures of how sexy you can be when you participate in a trial. So just generally, what motivates CHIM participants? And here I just want to quickly get some general things out. There's there's a lot of studies that have been done in this area. I just want to highlight one or two. So Maria Astrid Hogewerf from the University Medical Center in Leiden. I guess this title already gets at the question that I think we will probably get into in some of the questions also about are participants just money-oriented risk takers or deliberate decision makers? And I think already this slide here where you see the people who really participated in CHIM in blue, and then a control study population of people who I just asked, hey, would you participate in CHIM? And those who said yes, these are the control P, control positive. You will also see control negative in the next slide. Basically overwhelmingly say that they want to contribute to science and they want to contribute to developing countries and that they're just interested in it. Of course, the financial compensation also plays a big role here. And also, I think we have to keep in mind, even though this is anonymized, that people are self-reporting, so there might still be some virtue signaling in there, but generally people say that they do this mostly out of altruistic reasons. If we consider what influences their decision to participate, it's very much the trust in the study team, and I think that's understandable if you entrust them your safety, but also, of course, pragmatic things like time investment or the severity of symptoms that you might experience during this time. And this isn't too different from the control populations if you average them, but you can see a clear difference, for example, in chances of developing symptoms between those who are in the control population but decided that they wouldn't be enrolling if they could. So I think that just shows you that people who are deciding not to participate are more concerned about that than people who want to participate. So something that's really cool about this facility where this was done is, first of all, I like that it's a foundation. So they are basically a CRO, but with all the winnings that they make, they reinvest it in just research that they're interested in themselves. And the next cool thing is that they do CHIM trials, but they also do phase 1 trials in the same building with the same recruiting method and with the same kind of staff. So you can make head-to-head comparisons between the populations of phase 1 trials and CHIM trials. And this paper isn't out yet, but yeah, there will be a comparison of the two coming out. I don't want to show you any peer-reviewed data, not peer-reviewed data yet, as it isn't yet published, but I can show you already the populations, and something that I think that's quite interesting there is that in the CHIM trial, you have a higher percentage of female volunteers, you have a younger population, you have more students, you have almost no unemployed people within this same center, so like 1% versus 49 in the phase 1 trials. And there's a higher percentage of medical related occupations or studies. So I just thought that was quite interesting there. So generally, what do participants want? They want purpose and impact. Of course, they want to be relatively safe. They want to have reasonable time and logistics, trust and care, agency fairness. Some social context does also matter, like what does your family say about participating, for example, and feedback and recognition. But what about hepatitis C CHIM trials specifically? So there we checked our database basically and invited people to participate in a online survey where they were compensated $50. And there was a description of the proposed CHIM trial and also a description of hepatitis C with a comprehension test. We asked many people via email to take part. Some started and some finished. And 117 only passed the comprehension test, so I guess it was important that we had it. And those are the people we're now looking at. Overall, there's a broad support in this population in our database to have a CHIM, which is the first by here. You can ignore the table, I think it's too small. And also, many people there said that the likelihood of them being interested in taking part was quite high. overall, the motivation we see here are very, very strongly altruistic. So to help others and save lives, by far the first one, and to contribute to the general progress of medicine. But of course, receiving financial reimbursement wasn't unimportant. It does matter. And also things like finding out about your own health. People are just generally interested in learning in these trials. The concerns I have were mostly about long-term health effects, understandably, with something like hepatitis C, especially where so many things are still being discussed. Their safety in general also, and also things that are more pragmatic, like loss of productivity. If you're enrolling and dedicating half a year of your life into a study, what does it actually do for the rest of your life, even if you stay perfectly healthy? So other factors to consider here, again, people would like to see their own health data, see the study results. I think these are very easy things to implement to make studies better for the sake of participants that I think are not nearly done enough. Just very quickly, the study demographics here, just two things to point out. The educational attainment of the people in our database is very, very high. And another thing is that I noticed is we have a bit of a diversity problem. So it's overwhelmingly white people and also overwhelmingly male people in here. So I think that's something that is important to keep in mind. So how does the hepatitis C CHIM actually stack up? We did a couple of things in order to just see generally how to feel about the hepatitis C CHIM. As I said, like, we don't have the expertise to understand all of this ourselves. So one important thing for us to do is always the expert consultation. And I think something that worked quite well that we've done here is basically, I think I can skip the slide, which doesn't work anyways, so that's good. But luckily, because of the great talks of Justin, Nagla, and also Kimberly, like, I'm set up well. So that slide would have showed you just basically what things are hard to do. The field trials are very hard to do. There's no really good animal models, all these things, and CHIM would solve a lot of these, so that's a table that we just missed because it didn't convert properly. But yeah, we convened this joint statement. Basically, what we do if we want to see, like, is a CHIM study useful in a certain disease area or not, is to ask experts, see what the experts say, but not just in science, but also in this case, people who are at risk, so people who inject drugs, community representatives, people who would be involved in the trials, like healthy participants, and of course the scientists. So many of the people actually in this room helped us formulate this joint statement and our signatories itself. And yeah, all the things that are in there you've already heard at some point today, but generally that it would aid the cause of getting a vaccine faster to have a hepatitis C CHIM that is reasonably safe, and yeah, all these things. So of course, and also our main task is to represent the participant perspective. So this is why we've done the questionnaire that you've just seen the results of. And because we were actually involved in the 2 trials that are proposed in Oxford as well as in Toronto quite early on, we have the chance to very early on implement the wishes and the needs of the participants. Like, for example, in Toronto, we set up an advisory panel in order to better advise on, like, how you can do things like make it easier for participants to participate from a logistics point. Excuse me. So I think these things are really helpful, and because we are involved so early and participants are involved so early, I think it really helps in order to stack up well there. Then in order to have a useful CHIM trial, it needs to be the case that there are vaccines after that you can test. I think that was covered enough before, but yeah, basically my very first and beautiful task at One Day Sooner was to talk to all the different experts who are working on hepatitis C vaccines and basically consolidate what their thoughts are and where they're standing. And thanks to the great help of Seongbom and Jake Liang, who put a lot of more work into this, it could actually be published. And so the list you saw earlier, there's a long list of vaccine candidates in the pipeline, and I think everyone's just desperate for those more phase 1 trials and actually getting human data. And what we also hope generally is that I think a clearer regulatory path forward will also encourage more funding for phase 1s in general, not just CHIM trials. So that's one of the hopes that also is on the back of this CHIM trial. And then, of course, you have to not alienate the public. Of course, when I first told friends that I'll be getting malaria for science, their reaction, like, even though they like and know me, was a bit like, okay. And I think that's something to avoid, and like having resources out there that you can just point to say, hey, this is not just something crazy that some scientists say, but like, here are the reasons why this is not just a stupid idea. Can be really helpful for participants. And finally, now that we've seen that the social value and the impact that a study has is one of the most important things that participants care about, we talk a lot about how much money they get for the time, but we rarely consider actually what is the impact of the trial we have, and I think that's a shame. I think it's a bit of a problem that like every single paper that I signed to participate in a study said there is no direct benefit of participating in this trial, and that's something that I understand you have to do. But I think that's sad, because obviously if that was the case, no one would participate in a trial, no one would run a trial. So I think if we think that the real payment for participants to participate is the impact that the trial could have, there should be more resources out there to evaluate what that could actually be. So as a service to our participants, we tried that. I think, again, a very aptly named paper. I understand that, of course, we have to keep in mind that all doctors have this oath to don't cause any harm. But I think it's always important to consider which harm we cause by not doing certain things. And I think this is certainly the case for a lot of experiments that we're not doing. I know this is controversial, you can ask me about that. But generally, when modeling this, we have to take a lot of assumptions. So just with these assumptions we worked in here, if we had 3 vaccine candidates to be tested, each with an 11% chance of success, so a total 30% chance of at least one successful vaccine, and we just assume that a controlled human infection model would shorten those timelines, we'd be looking at about 185 infections averted with 20% of vaccine uptake globally. But of course, what I want to show you is that these are just some numbers, and it depends so much of which variables you pick, and we don't know this. So these risk-benefit ratio horizons you can see here, you can see they definitely depend on the vaccine uptake, of the difference in trial length, but also on how many studies you conduct and what the percentage probability is of a candidate to succeed. So instead what we did is we did a Shiny app online that you can just look up and you can play with the variables yourself. All the code, all the math behind this is also publicly available. And I think we're a bit worried that we're, as people who are like representing people who want to be in challenge trials, of course might have an incentive to have trials be looking good. But I think that's really what we don't want, because the last thing we want is to have something that's not accurate and then afterwards CHIM trials suffering because of that. So we actually also run a modeling competition to prove this model wrong, which I can talk to you about if you're interested in that later. We also working with Nick Scott's team in Melbourne to get a new cost-benefit analysis going on hepatitis C vaccines that's more up-to-date than what's already out there. So please stay tuned for that. And I think overall, this is just how we think that a vaccine trial should be safe enough to allow grown-ups to make the decisions whether they want to take a risk to benefit to society in order to do that. We think that there are enough vaccines out there to reasonably have a huge impact if a CHIM would be there, and that the social value, as I said, could be quite great. So thank you very much for your time. I also want to thank all the researchers that I've mentioned and my awesome colleagues. Basically, this is our small trial team. So as you basically just 90% of the work that's happening, me doing the research, Raquel, who speaks to all of our lovely volunteers and organizes them, and Jonas, who didn't have a chance to review my slides, so it's all on me.
Thank you, Paul, and I personally want to thank One Day Sooner for the amazing work that they have done, not just for the HCV CHIM, but I think just for raising the profile and supporting participants participating in challenge trials around the world, and they've been incredibly helpful to both Ellie and to our group in Toronto to try to move things along. So thank you for all the work and the advocacy. I think maybe we'll keep the questions to the panel at the end, because the next 3 talks are all about challenge studies, so I think it would be nice to have a comment from all participants. But thanks so much, Paul. So you can sit beside me. So now it's my pleasure to call up Ayub Mahassin, who works with me, who's going to introduce our next speaker, Charles Weijer.
Hi, it's my pleasure to introduce Dr. Charles Weijer, who is a professor of medicine and philosophy at Western University in London, Canada. He's a leading expert in the ethics of randomized controlled trials and from 2008 to 2013, Charles co-led a collaboration that produced the first international ethics guideline for cluster randomized trials. He led the writing team for the World Health Organization guidance on ethical considerations for health policy and system research, published in 2019. In 2020, he served on the WHO Working Group for Guidance on Human Challenges Studies in COVID-19, and he currently co-leads an interdisciplinary team exploring the responsible implementation of novel technologies in organ donation, including normothermic regional perfusion. Charles held the Canada Research Chair in Bioethics from 2005 to 2019, and in 2016, he was elected to the Royal Society of Canada.
Okay, I think I'll do just that. All right. Well, thank you very much, Jordan and Justin, for the invitation today. It's a real pleasure to speak with you about the ethics of CHIM studies involving hepatitis C. So there have been a lot of CHIM studies over the past 50 years or so. Probably 20 infectious agents have been studied, from relatively innocuous infections like the common cold all the way to more serious illnesses such as malaria and cholera. These CHIM studies have really played an important role in the development of vaccines against cholera, dengue fever, influenza, and malaria. Importantly, the safety track record in CHIM studies has been exceptionally good. Just a couple years ago, there was a large systematic review tracking over 15,000 participants in CHIMs over the past 40 years or so, and it demonstrated a challenge-related serious adverse event rate of only 1 in every 500 participants. So that's actually remarkably low, and importantly, there have been no deaths in modern CHIM studies. So which kind of leads us to this question. Well, what about hepatitis C virus CHIM studies? I've been doing research ethics for a long time, and I well remember the time when this was just one of the things hepatitis C was one of the things that you just sort of raised as, well, obviously you couldn't do that because there wasn't highly effective treatment for hepatitis C, and also, of course, as we all know, there are serious long-term consequences to hepatitis C in infection. It's exciting that things have changed, right? There's been a major change in terms of the availability of direct-acting antivirals, or DAAs, and that really, I think, prompts the question whether now we can consider potentially hepatitis C CHIM studies as being ethically permissible. So a couple of years ago now, wrote a paper with Jordan and Jake Liang and Annetta Ridd at NIH, laying out an ethics framework for hepatitis C CHIMs. And we set out, there were 10 sort of aspects or elements of this framework, and basically our argument was, for any hepatitis C CHIM that could satisfy all of these elements, we thought that study could proceed ethically. So in what follows, I'm not going to go through all of these, but I'm going to highlight 5 or 6 that I think are sort of the most salient for our discussion this morning. The first is that there needs to be sufficient social value. So hepatitis C CHIMs must generate knowledge likely to advance the global elimination of hepatitis C virus. Unfortunately, as we've heard, the strategy of treatment as prevention has faltered globally due to a lack of access to testing and high reinfection rates. Plainly, a vaccine is needed, but it's unlikely to be developed currently due to high development costs, no suitable non-human animal model, and as we've heard, just some of the enormous challenges in conducting field trials. So I think CHIMs here can play a really important role in that vaccine development pathway to gather efficacy data on existing vaccine candidates. And I think it's also really important that in order to maximize the social value from these studies, that we carefully and rigorously prioritize vaccines for downstream field trials. Second, these studies need to have a reasonable risk-benefit profile, and in this context, that means that risks to participants and third parties need to be minimized, and risks need to stand in reasonable relation to the social value of the study. So let's unpack that a bit. Well, we know that acute infection with hepatitis C is relatively low risk. Most people are asymptomatic, and the risk of severe acute hepatitis is very low, with less than 1 in 1,000 people developing that complication. Furthermore, we know that there's a very high cure rate with DAAs in this setting, a cure rate approaching 100%. In CHIMs, there's more we can do. So the infectious inoculum needs to be derived from a donor who's been cured with first-line DAAs. And of course, the infectious agent needs to be sequenced to exclude mutations that may confer resistance. There's more we can do to mitigate risk in CHIMs by study design. So the first few participants in these studies ought to be infected and treated sequentially. By that I mean one at a time. We don't want to infect people in groups and then discover there's some unanticipated problem. Furthermore, I think we need to establish the safety of a 3-month delay in treatment before increasing that duration of infection, say, to 6 months or so. Third, there needs to be fair participant selection procedures. And in these first-in-human studies, I think that means prioritizing, minimizing risk to participants and third parties. So let me say something about that. Minimizing risk to participants would involve restricting these studies to young, healthy volunteers who have no liver risk factors. And furthermore, individuals should provide upfront consent to treatment with DAAs upon study withdrawal or completion. It's sort of not enough, I think, that we minimize risk to participants. We also need to be thinking about minimizing risks to third parties. And here, study participants would need to agree up front to notify intimate partners of their participation in the CHIM. They need to agree to use condoms for intercourse and not share any personal devices that could break skin or mucosal barriers. Furthermore, these early CHIM studies, I believe, should also exclude people who engage in behaviors associated with the transmission of HCV, and that would include PWIDs, as well as health providers who perform exposure-prone procedures, such as surgeons. Next, there need to be robust informed consent procedures in hepatitis C CHIMs to ensure the informed, voluntary, and comprehending participation of competent adults. The purpose of this is not for you to read all the details, but there's a long list of, fairly complicated stuff that needs to be disclosed for people to participate in a hepatitis C CHIM in an informed way. And that really poses a challenge to researchers. I think the key here is to proceed with evidence-based methods to promote comprehension in study participants. So what are some of those evidence-based methods? I think it's important that we partner with educators and stakeholders to develop effective educational and consent materials. Second, it's important that all participants have the opportunity to meet one-on-one, to have a discussion with research staff about the study, to be able to ask questions and have those answered. That's something that's been proven to enhance comprehension in the research-informed consent setting. And finally, comprehension of all of this material needs to be tested, and any gaps identified addressed with education and retesting to really make sure that participants understand what they're getting into. Next, there needs to be proportionate compensation. And I'm going to unpack compensation in a number of different bins, if you will. The first is that study participants need, of course, to be reimbursed for any expenses, right? So childcare, parking, transportation, all of that kind of stuff unproblematically needs to be reimbursed. Furthermore, they need to be compensated for the time that they spend engaged in study activities, right? Clinic visits, that sort of thing. They need to be paid. I think the appropriate relevant rate is the locally applicable wage for unskilled labor for study-related activities. So basically, minimum wage for their time participating in the study. A really interesting difference, I think, between hepatitis C CHIMs versus other CHIMs that have been conducted is that CHIMs up till now have mostly been dealing with sort of acute infections that either resolve within a few days or a couple of weeks, something like that, or people achieve an endpoint and they receive curative treatment after a week or two, right? And so they might be paid for their time while in quarantine, for instance, but then the study's kind of over with within a week or two. Here we're talking about people being out in the community, infected with hepatitis C for a period of 3 months or 6 months. And how do we even think about compensating people for that? I have to say, I don't think I've entirely wrapped my mind around this one, and I think it's going to require more conversation. But I do think that modest compensation for the time spent infected is likely appropriate. But beyond this, I think we should be cautious about additional financial incentives in these studies to promote enrollment. Finally, and very importantly indeed, stakeholder engagement. It's really important that we engage relevant stakeholders to inform the study design and to promote transparency and accountability in these studies. That means engaging with a bunch of groups, importantly, to engage vaccine developers and regulators on scientific aspects of these studies, to engage prospective participants and advocacy organizations to inform study design, educational materials, consent materials, and finally, to engage people living with or who have experience of hepatitis C virus and PWID communities to promote transparency and build trust within those communities. So I think if each of these aspects of the ethics framework can be achieved in a particular hepatitis C CHIM, that it is ethical to proceed. Indeed, I think developing such a model should be a priority on the path towards global elimination of hepatitis C. Thanks.
Thanks, Charles. I'll ask you to join us up here on the panel, and then I'll ask Ayub to introduce our final speaker of the session.
And last but certainly not least, I would like to invite Dr. Yves Dubè, who is a professor of anthropology at Laval University in Quebec City, and a researcher at the Centre de Recherche du CHU de Québec, Université Laval. Her field of expertise is anthropology of public health, and she's particularly interested in the social, cultural, historical, and religious dimensions of infectious disease prevention. She holds a Canadian Institute of Health Research Applied Public Health Chair on the anthropology of vaccination, and she chairs the Social Science and Humanities Network of the Canadian Immunization Research Network, as well as being the scientific co-director of the Bridge Research Consortium.
Thanks. Oh, okay, I get the weird feeling with the slides. Thanks for having me, and I'm afraid that I won't be speaking about CHIM, so bear with me, but let's pretend that you've worked all really, really hard to figure that out and you develop a vaccine that is safe and effective, and now that you want to implement it. We now know that vaccination are becoming or are increasingly becoming a polarized topic. We are seeing a global decline in vaccine uptake rate for routine vaccine. Canada lost its measles elimination status recently. There's an increase in politicization of public health discourses, and lack of confidence and misinformation have been identified as the main barriers to ensuring high vaccine uptake rate in the future by WHO. Now, what we know about vaccine acceptance, first of all, we often tend to think about vaccine as yes or no, but there's a continuum of vaccination decision and attitudes ranging from a small minority, when we look at different high-income countries, a small minority of vocal vaccine deniers. Those are the ones we tend to stick on, but there are a really tiny minority, and at the other end of the spectrum, we have a large majority of people that accept all vaccine with confidence. And in the middle of this continuum are the vaccine hesitant. In public health, vaccine hesitant people are the one we like to work with to better understand their concerns, because there's between 25 and 30% of the population that could be having some level of ambivalence towards vaccine, and that there's the one we need to convince to stay on with our program. We often look at vaccine decision as well, looking at the individual attitudes, belief, behavior, but there's those decisions about vaccine are made in a social world, so there's many other factors that impact why people accept or refuse vaccine: peer-to-peer interaction, the provider recommendation, community norms, how accessible are the vaccination services as well. So what we aim to achieve, the title of my talk was How to Build Confidence in Vaccination. We need to be proactive. Confidence needs to be prepared. And we know that when there's a new vaccine, it's a point where people are paying more attention, and we need to prepare for a new vaccine introduction. How do we do that? Vaccine acceptance is complex, it's multidimensional, it varies across contexts, it evolves over time as well, so we need to listen to communities. As was greatly said by Kim, everyone's different and every context different, so we need to adapt our strategies. So I'll briefly introduce you some of the data that we've collected recently. So VBAP stands for Vaccine Behavior, Attitudes and Practice Survey. It's a project that we're doing with the Bridge Research Consortium among a Canadian population. So what we're seeing, this is the latest data collection point collected in last December, is that overall Canadians have positive view about vaccination. They all believe vaccines are safe, effective, compatible with their belief, and important for children to have. But when we look at those items in a more granular way, what we're seeing is that younger respondents tend to have less positive attitudes, especially the 25 to 44 years old. And that's of concern for public health because these are the parents and these are the ones making most of the decision for childhood vaccination. Maybe less relevant for hepatitis C, but still in terms of public attitudes of concerns. We've also asked different questions about new vaccine technologies. mRNA is something that we know quite effective to develop new vaccine, but when we ask people what they think about that, if they consider that these new approach are safe, it's almost 40% that disagree with that. We've also have shown that people have limited knowledge in how vaccines are monitored, approved, tested, and developed. But interestingly, and I forgot to add that on my slide, 60% of respondents said they would be more willing to accept a vaccine if they know more about all this process. And then when we ask people whether they consider themselves to be vaccine hesitant, we see that a third are hesitant, with a higher proportion, again, in the 25 to 44 years old. And we have different profile of participant. Pay attention that almost 30% of healthcare workers do have some level of fears about vaccines. So quite something, because, yeah. So how can we build trust in vaccine? Of course, we need to tailor our intervention for where people are on the spectrum. If you are willing to accept vaccination, you need to have good access. You need to be aware where to go. But if you're more ambivalent, then it's when we need to implement strategies to build trust. So trust-building communication, I've put a quote from a report by the Carnegie Institute. If you want to be depressed, go and read that report. It's all about how the new communication ecosystem has influenced how people trust in science and institution. But what I'd like to argue today is that scientists and public health are working on outdated assumptions about how trust works in the real world. When we face distrust in science, we have a tendency to provide more of what we believe is the right information. And then once people will be more informed, then trust will increase. But guess what? It's now how it's work. Especially with internet and social media, now what we're seeing is that engagement with a story has more impact than accuracy of the fact of that story. That emotions are much more powerful than fact to make people change their mind. That authenticity, whether you speak from an authentic point of view, is more important than whether you have a degree or an expertise. And that networks are much more influential than hierarchies. So when we think of science and the way we communicate science, we're not there at all. So that's why people are more prone to believe in what an influencer has said on social media, that vaccines can cause you to whatever the false information. But reassuringly, when we ask people in our survey, who do you trust the most to give you vaccination information, it's healthcare providers that are the top listed. And then scientific experts, which is good. But also pay attention that the third or the second is close contact and relative. So what other people around you are saying about vaccine is as influential as what an expert could say to you. So we know that healthcare providers have a huge impact on whether people will accept or refuse a vaccine. And it's not just what they say, it's how they say it that is influential as well. But often, healthcare providers feel a bit disempowered when they face someone with a lot of question or ambivalence towards vaccination and they don't know how to act. So I'm showing you a slide from a program that we have in Quebec based on motivational interviewing techniques. So those are counseling techniques that are used in drug addiction. But we've tested this for vaccination to speak with vaccine-hesitant people, and it shows quite effective in helping people overcome their ambivalence and and accept vaccination. And it's all about trying not to correct false information or what we think as expert is false information, but instead trying to understand what makes that person think about vaccine and address that specific concern. And of course, when we speak about vaccine acceptance, it's hard to not speak about mis and disinformation. We know that with online and social media, there's a lot of false information out there. This is a slide. So I've done, during the pandemic, I was doing social media listening as part of my role in public health. And this is just a snapshot of discussion in Quebec social media about vaccination. And what we are seeing in that slide is that it's all people speaking among themselves. So when we put our little thing on LinkedIn or Blue Sky or whatever the platform you're using, we tend to reach people that have the same belief as we are. And that's true for us experts, but that's the same for people with anti-vaccine belief. And often in science, when we came across a false belief, we have this reflex of wanting to correct this information. But speaking with science journalists or experts, trying to debunk a myth, it takes a lot of time. You need to go find out studies, have the good data, look at the myth, and develop your argument. But creating a myth is quite fast. You know, you could be in your basement and spending a lot of myths. So when we look at all the false information that's online, we need to be careful in investing our resource on the one that are most likely to stick. And often it's not worth trying to address everything you came across. But if you want to do this, there's good strategy. And I keep seeing that in my work again and again and again. You know, vaccine do not cause autism in big red letter. And then why this is not true in small fonts in black. But guess what? People will remind that, oh, vaccine, autism, there's something. Because I keep seeing that vaccine don't cause autism. So you need to lead with the fact instead of putting, again, the myths out there. And a good strategy that is really, really effective is to beware people that they might come across false information when they're online. It's called pre-bunking, and it's a simple strategy. And I know clinicians are using it in their own practices. It's just to say, you know what, if you're Googling some question, you might come across false information. If you have a specific question, please do come and ask me. And we need to fill the gap. So if you say that vaccine don't cause autism, what is the cause of autism? Because people want to know. And so that's a tricky one. And finally, as I said, vaccine acceptance is complex. We often tend to focus on what people think and feel about vaccine, but we need to, if we want to effectively raise vaccine confidence, we need to work as well on social processes, trust messenger, a positive social norm around vaccination, motivation with incentive and disincentive, but also practical issues, making vaccine services accessible so that people can easily access, removing structural barriers to vaccination. So my key takeaway, vaccine confidence is complex, it's context specific, it evolves over time. Remember when the first vaccine against COVID were made available, people were lining up to get their shot. People were angry because they were not prioritized to be vaccinated first. And then a couple months later, we were in a completely different situation. I'd like you to remember that more information or more facts will not increase trust in vaccine. It's not a problem of being ignorant about science or not knowing. It's much more complex. And if you'd like to build vaccine confidence, I'll argue to identify in your context, in your situation, why people are mistrusting vaccine to tailor your intervention. I think I'm done.
Yes, please. Yeah. So we've got about 15 minutes for questions. Maybe, Kim, I'll call you back up if you don't mind. Yeah, there's one more chair. Great. And so questions about CHIM, about vaccines, about the vaccine study, all fair game. Jason.
Jason Grebley from the Kirby Institute. Fascinating talks from everyone. Eve, that's really amazing. I guess what I'm wondering is, and you kind of alluded to this, but do you have any thoughts or suggestions? It seems to me that we need to be working maybe more closely with our social marketing sort of colleagues working in different disciplines, and it's going to be super challenging, but we need to get more intentioned, and it's going to vary by setting and all these different things. But just your thoughts on that. I don't know if you do social marketing as well, but what your thoughts are on that, because it just seems like we need to be a little bit more intentioned with what the asks are in our health promotion campaigns and be a bit more strategic. I don't know what your thoughts are, though, if that makes...
Yeah, and I believe that public health is under-resourced when it comes to communication. And often what I've seen and what I believe is the worst is that communication teams tend to work in silo and not maybe are in touch with like the vaccine experts. So there's often a gap in what the communication are, so that we had a campaign in Quebec that compared HPV vaccine with the STD's belt. It was poor. People were angry. It was shut down, but that was all due to a marketing team trying to develop their own thing without the content expert. And I think everyone has a role in making sure the science is accessible, is understandable. So all experts in this room are really knowledgeable about Hep C and future Hep C vaccine, but maybe that's not communicated enough outside of our...
Thank you.
Emmett.
Yeah, I want to first say I really appreciate this panel as a social scientist to see other folks doing social science research in this space. But my question is for Charles, and kind of taking the question posed in the first talk of benefits and expansion of benefits for CHIM participants. I was wondering if there's been any thought in the philosophy side of taking L.A. Paul's theorization of transformative experiences from the philosophy realm and using that to think about, like, we know we have some participants who get involved in CHIMs or HCV research from a lived experience perspective and then go on to careers in medicine, research, participant-engaged research. And I was wondering if there's any factoring of kind of the possibility of participating in a CHIM as a transformative experience into the benefit analysis. I know L.A. Paul is hard to theorize with for CHIMs because of her questions of rationality.
Thank you for that. I don't know L.A. Paul, but you know, so I look forward to doing some learning on that. I mean, I do take the point that we do a very bad job of informing people of the benefits of research participation. I'm a research ethicist. It's not me. I'm not doing this, right? But REBs do this, and IRBs do this south of the border. And I don't know why this language of, you're not guaranteed any direct benefit by participating in this study tends to be all one sees in a consent form. And I think, as an ethicist, that's really problematic. We need to motivate people's decision-making about participating in the study. And if all we're telling them is risks, and we don't say anything about benefits, then rationally, why on earth would anyone participate in the study, right? So yeah, I mean, I think where there is the potential for direct benefit, I think we need to communicate that clearly and, with the appropriate caveats. But I also think we need to take a broader view of benefits and talk to people about the social value of study and what researchers hope this is all about. So for instance, in a hepatitis C CHIM, I think it would be important to situate that CHIM in a pipeline of studies that ultimately, hopefully, would lead to an effective vaccine. So we need to do, ethically, we need to do a better job of informing people about benefits, the benefits of study participation as well as the risks. So yeah, quite agree.
Thank you so much.
Sure.
Sophia Bartlett from the British Columbia Centre for Disease Control. In the discussion around the potential harms or risks for participation in a HCV CHIM, one of the things that I didn't hear mentioned was the potential for stigma and discrimination while someone is living with hepatitis C infection. And I think that's a very realistic risk. For example, you might need to go to the dentist during the time when you're living with hepatitis C. You might have a new sexual partner. And even if you're wearing condoms, you should probably tell them. So there's a lot of potential for people to experience stigma and discrimination. And I'm just curious why I didn't hear any mention of that.
Well, you will be happy to know it's in the consent form that we've, so that it.
And does that not
an
factor
important
into the compensation piece?
Can I say something?
Sure, please.
So I've been doing research with underserved populations for a really long time, and honestly, there's a marketing thing here. And why was it called the VIP trial? We want people to feel like they are VIPs in this. And all my trials and many others, we make sure that the messaging around that trial makes people feel important, valued, and critical to the mission.
Oh, I don't think they'll be stigmatized in the trial. I think it's everyone
I know,
else
I
who they
understand.
interact
I know,
with, right?
but so we start there. And we keep, and we're working with the population, and we're also working with community stakeholders. So it grows. And the VIP thing became like, I want one of those sweatshirts. I want one of those beanies. So there are ways, and I think that we do address it, but we need to be more specific. I think it's really, really important because that's one of the big things under the iceberg, like Julie showed in her slide yesterday.
Please.
Just quickly to comment on that also, I think it's a great point. I think the reason why I personally didn't have it in my slides was just because when talking about why participate, it didn't feel quite appropriate, but I think you're absolutely right that it should have been a part of this conversation. So there's not, because or any of us think that it's not a problem, I think.
And just as a point, I did mention it is in the consent form both for during the period of infection, but also the state of being antibody positive after that people may be recognized as having had Hep C, and that might make presumptions about risk.
We did address that in VIP.
All kinds, yeah, so that's very clear, and I mean, I think it's a really good point, Sophia, but we have highlighted that. Jake?
I have a question for Eve. Thanks for laying bare all the reason for increased vaccine hesitancy and decreased vaccine acceptance. You talk about the importance of healthcare provider in convincing the general public, but how about what the public health officials say and do affect the overall attitude of vaccine acceptance, right? And also the second thing is, maybe it's not so much an issue in Canada, but at least in the US, reimbursement of vaccine is important if the policy is not supporting or whatever there's issue. How much does that really affect that? Because I haven't seen any data in terms of how that really increase the vaccine hesitancy and decrease vaccine acceptance. I mean, do you think that's going to play an overwhelming role in terms of swaying the direction of the vaccine acceptance?
Yes, definitively. We've just published an editorial on political vaccine hesitancy. The political leaders' decision will have a huge impact on people's acceptance. We are seeing in Alberta a ban on mRNA technology in vaccine as well, so it's not unique to a particular context. There's a risk-adverse group of political leaders that have huge impact, and all those decisions impact access to vaccine as well. And I've been working on moral injuries. You know, a public health official working in immunization are harassed, they receive death threats. So it's a toxic situation that has a unfortunate impact, and that's something we need to address. And even scientists often don't want to go online on social media to speak about their work because they don't want to feel that pressure. So yes.
So I guess it would be important to collect data going forward, right? To see
Yes.
what happened with these kind of situations.
Yeah, and Canadians are aware of
right now it's all reasoning, right? But it would be good to collect data going forward to see what happened to.
In so many ways, and briefly, you know now that when you ask something on Google, the first hit you got is a AI-generated answer. It's a black box, and we don't know where this AI is taking its information. But if it's coming out of the CDC and it's about vaccine, it might be misinformation.
Well, yeah. No comment.
Terrifying statement. Anton.
My question is for Eve as well. I was wondering if you could speak a little more about having a trauma-informed approach for conveying like information and trying to increase vaccine uptake, especially for something like hepatitis C, the priority populations being prisoners, indigenous people. It's like communities who historically have experienced a lot of harm from the government, healthcare providers, public health, but continue to. So it's not even something that's rooted in the past. It's something that they can still continue to still experience that violence.
Yes, definitively. One of my research during COVID was among Nunavik, among Inuit population. You know that at the time where the vaccine decisions were made, Inuit were prioritized to be first vaccinated. There was no case in Nunavik. And they were receiving the vaccine after white people in down south. And of course, they refused. They were like, why are we testing this vaccine? There's no case in here. We're testing it for you to see if it's safe before. So it's with people that have suffered inequities, it's really where we need to build trust. And I believe that we need to work with trusted messenger. There's people that are better than public health officials to convey that message, and that's where we need the support. We've seen great progress during COVID. I just hope that this will be sustained now that we're out of this pandemic, and that all these relationships that has been built will be continued and enforced.
Thank you.
Jennifer?
Good morning. My name is Jennifer. It's fine. It's fine. This is my normal. It's okay. Thank you. My name is Jennifer Van Gennep. I'm the Executive Director of Action Hepatitis Canada, and I just wanted to make a couple comments as the co-chair of the Community Advisory Board for the CHIM study here. I co-chair it with Jake from One Day Sooner. So we have a really nice advisory committee that's been going for about 2.5 or 3 years now. It's half people who have lived experience of CHIMs and half people who have lived experience of hepatitis C and are members of priority populations of hepatitis C. Part of the reason we're involved in the advisory community, what is it called? Advisory Community Board. Community Advisory Board is so that we can help disseminate the progress of CHIM and of Hep C vaccine studies through our community organizations. We have about 80 member organizations so that they can, so when a vaccine comes out, it doesn't come out of nowhere. And so that they know that they've been part of this all the way through. And so, like April is immunization month, so in our newsletter we'll have updates about CHIM and what we've been doing here with CHIM, just so people are kind of they feel like they're being brought along, and then we can also get input and these kinds of questions come forward in a way that they can be addressed. And then I just also wanted to note that the advisory board did push back quite significantly on the idea of unskilled labor and minimum wage compensation, because I'm sure there are some people in this room who had a physical reaction about unskilled labor and minimum wage. So I wanted you to know that we have spoken about that, and that has been taken into consideration by the study committee as well for when it comes to compensation. Thanks.
And I would just highlight a thanks to Jen and to Jake for helping us organize this community group that's advising. And I think it's important. It's not just handing them a protocol and saying, what do you think? They're really advising on developing it, both the compensation but also the way we do the studies. So it's been a really useful process. We've learned a ton from them. Heidi.
Hello, I'm Heidi Drummer from the Burnett Institute in Australia. I wanted to ask the question from the different perspective of, do we actually know what our target population want from the vaccine in terms of, you know, the type of vaccine, how many doses, how they'd like to receive it? Because to me, this is also an important consideration, that the end user is actually very important here and should inform our decisions on what also goes into the CHIM study. And I haven't heard any discussion about that, but to me it seems like a central question that we should understand, because it might also help us understand what work we need to do on vaccine hesitancy in this population. If we have an mRNA vaccine but they don't want it, what do we need to do to encourage them to take it? Or if we have two equally effective vaccines, it might help us decide which one to go forward with in the CHIM study.
We did some preliminary work like that before we did the VIP trial, and a lot of surveys and qualitative interviews, and you know, it was like, yeah, no more than 2 years, you know, how many vaccines. There's so many cool methodologies you can use, like random vignettes, different ways to look at vaccine preferences too. I think it's a very important first step in the target population.
Good question.
Yeah, hi, Ellie Barnes, University of Oxford. I wanted to ask about the participation questionnaire for the CHIM, Paul, that you talked about. I was surprised that at the failure rate in that, you know, questionnaire for kind of comprehension and understanding. And what should we do when people don't pass that test, if you like? I mean, do you then say, right, you're out, or do you say, well, you failed on these 3 components, we're going to educate you on that, and then we retest you? Because that's a bit kind of biased. How do you cope with failure in that questionnaire, which I'm imagining will be quite high?
I think it's a great question. The whole questionnaire is available online if you look for the paper, by the way. You can look it up. First thing that I'm thinking when I hear this is that it's one thing to offer people who are generally interested in the topic $50 to fill out a questionnaire. It's a very different thing to sign people up for a 3-6 month study and tell them they're going to be infected with hepatitis C, and you'd hope that they probably take a bit deeper a dive and a bigger interest in the materials that they're actually given. That at least would be my hope. The other thing is that quite often they didn't have the chance to be re-educated, right? They did the whole questionnaire, and then afterwards we found out, well, this answer isn't good enough that they give there. So I guess you have other tools that are more interactive in an environment of a clinic where you have people there who can talk to them. So I also hope that the consent form there and the information process would be way deeper than just, here are 3 pages about CHIMs and about hepatitis C. So I just generally think it's interesting to look, of course, what were the reasons, what are the things that people don't understand. Maybe we can design the 3 pages we had better. So that's something we can learn, but I don't think we should draw too much a conclusion from that, because I don't think it will translate too well to how people treat consent materials if they're actually enrolling. That's.
So it's not a tool for excluding people from participating, it's just an indicator that more education is needed? Or would we actually ultimately say you can't participate in this because you haven't objectively demonstrated understanding? That's my question, I think.
This is now a personal opinion. I'm a strong proponent of soft paternalism. So I think everyone who really understands what they're getting themselves into should be allowed to do so if they're the ones taking the risk. So my personal opinion is, just answering right now, I'm thinking as I'm speaking, so this is not ideal, but is that is that you need to make sure that ultimately when they enroll and they are being given hepatitis C, that at that point they understand everything they need to know. So I don't see anything in principle that is wrong with giving them a second chance.
I mean, just to, again, what we've done, whether right or wrong in approaching this, is provide people with the consent form. They review the consent form, obviously, they agree to participate, and then they take a test of comprehension. They can access the consent form when they're taking the test, so that if they want to review something, because we're not trying to see if it's not an exam, it's is the information there that they need to know, and they can take it up to 3 times. And I guess the way we looked at I agree with you that it's a bias to ask the same questions again, but our feeling about it was, what are the things you really need to know to understand the risk? And if you can appreciate what those risks are, and obviously what we think is important for them to know and what other people think, I mean, that's debatable. But I think the important point is that someone is taking away that information and internalizing it and being able to report it back to you. And I don't know, it's an imperfect system, but I think it's a reasonable approach. Justin?
Hi, Justin Presseau from Ottawa. Thank you to the panel for just an amazing discussion. I'm interested in your views on when is the right time for us to start building vaccine confidence in an HCV vaccine when we don't have one yet. But hearing what the discussion, it seems like the earlier the better. We have a CHIM environment in which there's a kind of social proof element here. So is now the time for this in the general public?
Yes. Yeah, it's never too early.
No,
I am, so this is a very rich discussion. I'm mindful of the time. I just want to, so if people want to ask a couple more questions, that's fine, but I just want to let people know there are a few lunchtime symposia that are happening now. If people want to attend those, they are starting now. So, and otherwise there is lunch down in the, where the posters and the exhibitions are. But, and if these last two questions can be short questions, short answers, and if people want to leave in the meantime, we totally understand.
Okay, amazing. Bernadette Latner here in Toronto.
Can you speak up a little? Speak up.
Sorry, I'll speak up. I just wanted to make a comment on the One Day Sooner campaign that was launched. There were messages that ended up saying get Hep C on purpose, right? And a lot of clients that I worked with at that time who used substances saw these but didn't necessarily have the phone capability to go to the QR code or the website, and so would come in saying, you know, they're telling us to get Hep C on purpose, what's this about? I would just advise that in looking at the way that the messaging can be interpreted by different individuals, to be very mindful of that, because then when the conversation did happen about this is a vaccine trial, then people said, oh, well, that would be something I'd be interested in. But that exact population who's seeing the message and it's most impactful for them are people who are not, cannot be part of trials initially because of the risk for ongoing transmission with ongoing drug use. So I just wanted to put that out there as a feedback that came to me directly from the community.
Yeah, absolutely. I can't say too much about that because it was before my time, but thanks so much. If I'd love to talk to you a little bit if you have time after this.
Last question, Vanessa.
Well, second last, maybe, I don't know. Okay, I'll try to talk quite quickly. So I partly have to give a bit of context here. So I'm Vanessa Myers-Stevens. I'm an infectious disease physician. We just finished a first phase 1 group A strep clinical trial, and they're talking about what's the next step. Well, the next step is CHIM. And as an ID doc, thinking, okay, I'm going to infect my patients. I'm going to, okay, right. 1 week, that's good. I can do that. And I'm getting involved in this hepatitis C vaccine trial. So I'm the lead for Mike Houghton's HCV vaccine trial in Edmonton, and of course we have sites in Ottawa and Toronto as we get this up and running. And then we're talking about CHIM on that front, and just the duration of that is just so much greater. And I'm hearing and I'm learning as much as everyone as well here today as well, and just in terms of all of these different ideas and concepts as well that have to be taken into account. One thing that did strike me in your talk with regards to the, why people enroll, why people get involved, the altruism being a big part of this and being part of the science and being part of all of that. And again, I definitely saw that with our Group A strep vaccine trial. One of the things that are kind of coming up in a theme with this is well, what happens next? So I get infected with hepatitis C. I can no longer donate blood. If my main motivation for helping people and contributing was to give blood donations as frequent as I'm able and that sort of thing, then that's now off the list. You had mentioned you were involved in a malaria trial even in and of itself. It's like, okay, well in Canada we're not you can't donate blood again if you've ever been infected with malaria. So there's these other implications around it. And I am gonna bring up and speak to the whole the sexual partners piece again, because getting infected, it's not just your decision, it's also your partner. And if maybe you've got a new partner, maybe you've got the bottom line is people have sex, and it's part of life. And if you are even in a stable relationship or whatnot, and you're no longer using condoms, now you're telling that person, okay, now you have to go back and use condoms for the next 6 months. It's not just your own kind of decision on this. There's a lot of extra components to this that come into play, but just kind of, I know it wasn't really short, but the altruism piece and kind of laying out the other implications that perhaps we haven't necessarily fully teased out when we talk about that compensation piece that I think are still part of this whole bigger picture. But I really appreciate you all bringing up all of these concerns and audience members for bringing these up as well. But thanks. I don't know if there's much of a question there.
Thanks, Vanessa. Again, just so you know, we have actually specifically put that in that you will not be allowed to be a blood donor if you, at least in the current context, if you participate in the trial. So I think these are really important points, and we're getting great feedback from the community about what are the types of information that need to be in the consent form, and then also being mindful about if we make it too long, then people don't read it. So those are all things to be thoughtful about. I'm very mindful of time. Thank you for this fantastic discussion, and to all of the speakers for really fantastic presentations. Again, lunch is there's the poster sessions. No, what? Karen, come up and tell me what I'm supposed to say because I'm getting it wrong.
This is the last session of the CanHepC portion of the meeting, so there was actually another line item on your program that maybe Jordan forgot existed. So Justin Presseau and Shay Colpitts just have a few kind of closing remarks, and then we'll give out the trainee poster awards for the CanHepC trainees. So maybe this panel, you're welcome to be seated. And I'm mindful that you're probably hungry because I'm hungry, and I've been giving Jordan eyes from the front row for a while, but maybe Shay and Justin, come on up.
Thank you, Karen. I failed.
Okay, so I'm also hungry, so we'll try and keep this pretty brief. So first on the list is going to be giving out the trainee awards, and then we have a few thank yous, and then Justin has some closing remarks for us as well. So I'd like to invite Joyce to come up and give out the trainee awards.
Okay, just to remind everybody, CanHepC is a training program. So while you were seeing posters and the talks, there was judging going on, and we have some winners. So I have 4, sort of at different levels. If you can hold your applause, so that we can do this quickly, and then at the end you can be super enthusiastic for all of them. So MRC. So first is poster awards for the MSc is Nathan Pilkey. So if your name is called, come up to the front. PhD level is David Lawton. Postdoc, Jawaria Atif. And oral for her lovely talk earlier today, Nicole Flores.
Congratulations to all the trainee award winners, and to all the other trainees. I think it was an excellent collection of talks and posters. So it's easy for Justin and I to stand here. There's actually a lot of work that has gone into organizing this behind the scenes. I'd like to thank Jordan and Naveed and all the scientific people who contributed to our program. Most importantly, I'd like to thank Anna, Lorraine, and Karen. We could not have done this without you. We could not have done 1% of this without you. And in particular, Karen, if you'd like to come up, we have something to pass along to you. Thank you.
Okay, I'm standing between you and lunch. Just some quick final thoughts, reflecting on the last day and a half that have been just truly tremendous. We've seen some compelling data, quantitative and qualitative, and multi-method research showing the potential of existing and innovative strategies, testing, treatment, harm reduction. We've also heard directly from the people in those numbers and in those quotes, whether they're people with lived and living experience and or the people supporting them. We've also heard a through line of the importance of political will and the challenges of its absence. But alongside that, and especially today, we've heard and continue to hear on the promise of vaccines. And so I'm left reflecting back on the last day and a half, feeling that this is not when we give in, this is when we lean in. And this network and its multidisciplinarity, its rigor, and how we centrally position authentic community partnerships and voices leave me feeling that we should be very optimistic and excited about the future. And in that regard, I look forward to seeing you again next year in Calgary. Thanks.